Welcome, everyone. I'm to this evidence-based mental health Google Hangout today. I'm Michael Ostacher. I'm the digital content editor for evidence-based mental health. We have a big panel, a terrific panel today. We'll be discussing John Torous and his colleagues' paper, Clinical Review of User Engagement with Mental Health Smartphone Apps, Evidence, Theory, and Improvements. And to lead our discussion and to introduce our whole panel, we have Lisa Marzano. She's a associate professor in psychology at Middlesex University, London, and the digital mental health section editor for evidence-based mental health. I'm delighted that we're all here today. We're streaming live, as if you're following us, you know this. You can also follow us on Twitter at EB Mental Health. And if you'd like to ask questions of our panel, please send us tweets at the hashtag EBMHchat, that's the letters EBMHCHAT, and we'll do our best to address them and respond to them live and bring them before the panel. So Lisa, why don't you start us off on the discussion and introduce our panelists today.
Thanks, Michael, and hi, everybody. We have a great panel today. Just for proximity, I will start with a special, unexpected, last-minute guest, Professor Keith Hawton from the Oxford University Centre for Suicide Research. He will be joining us on the call. We have John Torous, who's presenting some of his work. John is director of the Digital Psychiatry Division and the Department of Psychiatry at Beth Israel Deaconess Medical Center, Harvard Medical School, and as well as publishing extensively in this area, he's editor-in-chief of the Journal of Medical Internet Research. Hi, John. Ipsit Vahia is also joining us. He's a geriatric psychiatrist, clinician, and researcher, medical director of the Geriatric Psychiatry Outpatient Services at McLean Hospital and the McLean Institute for Technology and Psychiatry. And his work focuses particularly on technology and informatics in relation to older adults. Mark Larsen, who's joining us from the Black Dog Institute, Sydney, where it's 2 o'clock in the morning on Saturday, so special thanks to Mark for joining us. He's a research fellow. His work has looked at the application of digital technologies, particularly in relation to suicide prevention. And he's involved as well at the moment in novel ways of detecting mental health and suicidal risk through social media blogs. Last and by no means least, we have David Gratzer, who is a psychiatrist at the Centre for Addiction and Mental Health in Toronto, and also Associate Chief for Inpatient Care and Practice Innovation. He's Assistant Professor at the University of Toronto, writes widely, including blogs and blogs at davidgratzer.com. So, hi everybody, and thanks for joining us. Really excited about this hangout and hearing more about some of the work that John and his team have done in relation to, well, that's some of the work we'll talk about today, but particularly this clinical review around user engagement with smartphone apps and some of the barriers. So I'll hand over to you, John.
So thank you, and thank you guys all for listening. Thank you to the Journal for organizing it. I think this is an exciting topic for all of us to talk about because our apps are only as good as people will use them. We can have the best app, the best technology, the best sensors, the best interventions, but if no one's going to use it, it doesn't really matter. And the impetus for this paper was we realized everything we do in digital mental health or smartphone apps, of course, is going to have some measure of engagement. We're seeing how people use it, whether it's a focus group, whether it's a randomized study. And of course, every paper, every study is looking at engagement in different ways. Is it clicks? Is it what people thought? Is it surveys? There's no standard way to measure engagement. It's actually very hard to define what does engagement even mean in this space? What does usability even mean? So what we thought would be interesting is rather than kind of trying to make up a criteria and follow it, we would try to identify themes with a group of authors on the paper and say, what can we say about these themes? What can we kind of learn as general trends? and how can they be improved? And I think in some ways you could say it's this paper, a negative paper, saying no one uses apps, they're not useful. And no, that's not the point. Is to say that there's really good example of apps being designed the right way. You can look at Dror Benzie's work at University of Washington, working with patients from the beginning, Stephen Schuler at UC Irvine, doing a lot of great implementation research. So let's say if most apps that we go to the iTunes store, we go to the Android store, we type in depression, we type in anxiety, most of the apps that we kind of come back and find really are not useful or usable for a patient. So again, there's really great research happening, done by a lot of great groups that are doing this the right way. But in general, what our patients, or at least the patients I work with, are finding are always not those great apps. And I said, so I think what we did is we kind of looked at different themes. And the first one was we thought poor usability. And by poor usability, we mean that sometimes these things are just buggy and don't work. And I think anyone who's developed software-made apps realizes they don't come out perfect on the first time. But if you read a lot of papers or talk to a lot of patients, a lot of these apps have errors or don't work. So you're clicking them, you're using it for your mental health, and then it will crash, it'll say the wrong things, it won't be supportive, it'll have errors that would be comical if it wasn't actually a mental health intervention trying to help you. And so I think we just looked at overall, I said it's hard to quantify errors. I said not every app paper is going to say, hey, we had this many technical bugs. People usually aren't highlighting that, but we know from developing these systems that they can be hard to develop. They take iterations. You're not going to get it right on the very first try. And we looked at that in the context of a lot of these apps aren't based off user-centric design. A lot of them are perhaps taking what works today in paper and pencil or face-to-face and saying, well, it works today this way. Let's just make the digital translation of it, and that's going to be great. And sometimes that digital translation isn't perfect. It's almost like saying you love the book, so you're going to love the movie even more, or vice versa. You kind of have to start from the beginning. Just because it worked one way doesn't guarantee it's going to work. So you kind of have to start with the user-centric design. And I think, as I said, we even say in this section, while there are examples involving those with mental health conditions in the conception design of these apps, and we cite Dror Benzie's work, these are currently the minority. And I said it's a growing minority, which is good, but the majority of apps really aren't thinking about those things. Another issue we brought up was the concerns about privacy. I think since this work, I mean, we've all heard of now Cambridge Analytica, which came out kind of before, as we were doing this paper before, but I think if the foundation of a lot of mental health care and all health is trust, you really want to trust the app of information you're giving. You want to trust that the information stays safe and secure, that it's not being marketed by a company, it's not being sold, it's not going to someone's database that you can't control. And I think we keep seeing a lot of concerns about trust is still lacking in this space. A lot of apps, unfortunately, sometimes the business model has to be that you are the price of the app. Your data is what's driving the app, especially for free apps. So I think we have to be careful and mindful of the privacy concerns. And I think certainly it's on the mind of patients using them. This relates to the idea of trust, or kind of a lack of trust. Can you trust these things? Just because you type in depression into the iTunes store, Android store, you get back thousands of apps. No one can even actually have an accurate count of how many there are. We've thought that there may be over 10,000 if you include the mindfulness and the meditation ones. I've seen numbers higher or lower. But there's really no regulatory approval for a lot of the apps that you kind of see commercially available. I say certainly in journals, we peer review stuff, we work very hard, we critique each other, we make sure stuff is working well. There's no peer review for the App Store. I said all of us on this video could put together an app over the weekend, put out a spurious, wild claim, and it would probably be on the app stores in a couple weeks, or if not a week. And that's concerning that there's a lot of stuff that is less reputable than I think folks like us are working on. And again, I don't think it's that people are trying to mislead people. I don't think anyone has bad intentions. They just don't understand. The app developer may not understand what are the regulations for medical data. How do you keep it safe? What do I have to do to make sure it's useful? So I think there's just a lack of mutual understanding between all the different stakeholders, but that ends up leading to a lack of trust of what apps get out there. And I think the final point we brought up in the paper was, unhelpfulness in emergencies. If you take whatever app that a patient you know is working with and kind of read the terms and conditions, I would say there's a 90% chance that says, if you're experiencing a medical emergency or you're unwell, please don't use this app. Go talk to a real psychologist, a real psychiatrist, a real doctor in emergency room. We take no responsibility. This is just a health and wellness product. Anything else, we're not here for you when you're actually in the most need. And that's just that's not how these things should be developed. And of course, if you put that out front, but when you kind of look at the description, you say, this is an app to help me with mental health. And mental health, like all health things, there can be emergencies. We hope there aren't, but certainly I think it's a challenge. And so then in the paper, we kind of looked at different ways that we can begin to work on improving app engagement. Again, realizing there are people that are doing a very good job at this already. It's not like this is unknown territory, it's just small and growing. We talked at Jordan Benzies at University of Washington is doing it. Steve Schuller is doing it. Mark Larsen, the Black Dog Institute, is doing a very good job of it. Ipsit's group at McLean is doing it. Till White's at King's College. There's a lot of groups, MindTech in the UK. So again, there's many groups working on engagement, but it shouldn't be the fact that we can count on hands and toes how many groups are really focusing on this. We want this to kind of be the status quo that, of course, we're working on this. So I said, I won't go into all of the details we propose in the paper. I think it's probably a good time to open it up because some of them I think we'll discuss in the course of this paper, but that's kind of my whirlwind overview summary of this paper. And Mark, I'm impressed that you look wide awake at 2 a.m.
I won't necessarily say wide awake. There's been a couple of coffees consumed to try and keep it going. And unfortunately, our internet cut off bang on the start of the call. So I'm glad we're back.
But yeah, so.
Yeah. Well, as it's late though, should we can I ask a question of Mark actually to sort of follow up some of, thanks John for the very helpful overview of your paper and what some of the issues are in relation to this and challenges perhaps. But you mentioned particularly how unhelpful many apps can be when it comes to actual emergency. And Mark has done some work focusing specifically on apps for suicide prevention. Yep. And I wondered if you would be happy to say a bit more about that.
Yes, so a couple of years ago now, we did do a review of apps that are publicly available for the field of suicide prevention and looked at what sort of suicide prevention strategies are contained within the apps. And almost as an afterthought, we thought we would look at whether there was potentially harmful content in there as well. Thankfully, the balance was more towards preventative strategies, but there were some I suppose, unhelpful suggestions for how to manage a crisis contained within the apps. So I think John alluded to that point that, apps aren't necessarily getting peer reviewed, and with the best intention of some of these independent developers, harmful content might actually be getting out onto the app stores. We know from other work as well that there's best practice guidelines, particularly for suicide prevention apps. So things like always having crisis contact details available is a really important feature. But again, that's not universally implemented by all of the apps that are out there. And I think more broadly as well, just having a button to get help in a crisis, which then gives you the contact details for someone to contact or a phone number to call, perhaps isn't the best strategy when we're looking at apps for sort of higher risk scenarios like suicide prevention. And really, perhaps there should be some sort of more proactive follow-up that can be offered, so we're not relying on participants always to make that connection out to get help. So is there a way that we can get providers and services sort of being more proactive in contacting participants?
Can I ask the question? I'm not that hugely familiar with this area, although I have some small involvement. The local person locally who's trying to develop a CBT app. To what extent are the intervention sites broad in the sort of sense of general suicide prevention, so covering a wide range of possibilities? And to what extent are they more interventionist, you know, aimed at the individual and trying to, you know, specifically help that individual? I know that's rather a broad question, but it'd be interesting to have a sense of that.
So in our review, we found there's quite a lot of apps that just contained information. So, for example, were electronic versions of textbooks, or were contained PDF copies of, say, local suicide prevention guidelines. So we took the decision to review more interactive apps. So what we might traditionally think of an app where you put some information in, something happens, you get some sort of feedback back. So if it had at least one interactive feature rather than just presenting information, those are the apps we looked at. But what we tended to find was apps generally only implemented a single strategy, and we coded these quite broadly, and what was most common really was just trying to get people to link in with support from friends and family or from crisis services. So that's obviously a very helpful thing to do, but actually in terms of a therapeutic suicide prevention intervention, that was quite lacking in this review that we conducted.
And in terms of interactive interventions, actually involving a live therapist as opposed to automated responses or whatever, I mean, to what extent did you find those? And I think you intimate in the paper that those are much more likely to lead to higher engagement and compliance. I think that's right.
So I think just to be clear, there's two reviews here, one specifically about the suicide prevention apps, and we didn't look at compliance in that per se, but we really didn't find that many apps specifically for suicide prevention that included therapist support. But it's a good point. I realise this is sort of taking us away perhaps from what was talked about in the paper we're actually here to discuss today. So maybe I'll sort of...
The paper itself raises the question of, you know, how much interaction with an actual person might be important in terms of raising use of apps. And I suppose one of the questions there is, you know, to what extent are we talking about a person coming online because someone is is engaged with the app, and to what extent are we talking about use of an app as part of an active therapy with someone you've already met? I'm not clear how often, you know, we're talking about the latter. I suspect not very often.
Yeah, that's definitely the impression from the apps that I've been looking at in this space. Most of them really are self-guided apps.
They're sort of standalone apps rather than apps, so so-called blended.
I'm raising
exactly
the general issue about when people say to me, you know, what's the bottom line of suicide prevention? And as soon as I think about it, I think human contact. You know, and that's, I think, an important principle to bear in mind when discussing these apps. So the further they get away from being like human contact and interaction, I suspect the less effective they're going to be. Less attractive to someone in crisis.
I wonder if we open that comment more generally for the panel, perhaps to John. I mean, this issue around the human contact is not so explicitly raised as one of the key barriers or the kind of potential reasons why engagement is relatively low. I wonder what your thoughts are on that.
I think it's a very important question. It almost raises the idea. We know that the therapeutic alliance between a clinician and a patient is one of the best predictors of success in any mental health treatment, especially in any therapy. But it raises the question, what is a digital therapeutic alliance? And what support do people think that they get from this little box of a computer in a box? What beliefs do people put in it? What expectations do they have? We know that we can make people anxious if we take away their smartphones today. If you want to induce anxiety in people, take away their smartphones for a day. And I think there's some words that yeah. So I think it's an interesting case of, we know that people are very dependent on these to the point where they become anxious when they're gone, but we haven't really quantified what is the type of support that people feel they're getting from a completely autonomous program, from a program that's kind of a Wizard of Oz supported by someone behind a curtain, or from a chatbot itself. So I think as we learn more about what is a digital therapeutic alliance, who is it useful for, what are its strengths, where its weaknesses, I think we may begin to match the right types of tools to the right people for the right situation. But I think the point that you brought up is correct. We don't really know much about it, or who is going to work well for or not. And when we're dealing with something like suicide, it's probably best not to rush out interventions we don't know too much about.
Yeah, I think, John, you make some really good points. You know, looking at the galaxy of apps we have available, one is reminded of the old joke about Chinese the not very good Chinese restaurant. The food is terrible, but the portions are big. So you go to the app store and you type in depression, and there are hundreds, thousands of apps, and yet they barely make minimal standards. So you didn't cite this in your paper, but it was published in your journal, JMIR Mental Health. Shen did a paper with a very, very basic criteria for what you would want in an app on depression. That, you know, there's some disclosure, sources of information, there's some assurance of privacy of data, et cetera, and just by that rock bottom standard, 75% of apps were excluded. So, you know, it's a very heterogeneous world. But then you tap into the larger question, which is what would make it successful. So let's assume there's some basic standards here, but what type of a connection do you need with your therapist? And I think it's a good question. But when you look at the larger literature on e-therapy, some sort of human contact is important, and some sort of regular contact. And I think anything beyond that for substantive work. So beyond some basic psychoeducation, but if we've got a person with depression and we really want evidence-based cognitive behavioral therapy, I just don't think a standalone app that some guy developed on the weekend is going to do it. And I think the danger here is we're overselling the technology, that there is a role to play, that there is need and access issues, and yet hold on, this goes beyond just any app on any app store.
Mm. And I wonder to what extent people are using apps, and not just sort of apps that are developed for mental health, but generally using technology actually to engage not so much with therapists, but with peers. And we're seeing more and more emphasis on peer-to-peer support, and more promise, perhaps, of peer-to-peer support in this field. So I think the question of what the relationship is and what therapeutic alliance might be possible or not within a sort of digital context it's only part of it, because there's lots of other connections potentially. But I wonder, one of the things I also wondered about was because we talk about engagement with the apps, and to what extent can we really define what is low engagement? Because we know that low engagement with apps, if you want, doesn't just apply to smartphone apps or apps for mental health. Generally there's, I don't know what the stats are exactly, but people download lots of apps that they never open once, perhaps, if that. So there's a question of what's kind of low engagement, what's good engagement. If the question is engagement, what sort of engagement should we be aiming for? And perhaps what's a feasible level of engagement? Looking at some of the literature around the kind of effectiveness of these apps, and now I'm talking about sort of CBT apps, sort of thing for depression. Actually, there are apps that mostly require people to engage with them for a few weeks, whereas there are apps that are really talking about long-term self-management of particular conditions and symptoms, where there might be an assumption that people engage with these apps on a long term for sort of chronic issues, which perhaps is not really quite how people use apps. And I guess that then leads me to think whether apps and apps particularly are the best way of doing that sort of thing. and whether we perhaps need to focus more on passive data capture, so on the potential of smartphones, but not only smartphones, of capturing data, and that creates all sorts of questions in relation to privacy and ethics, etc. But can't we gather lots of really useful information without requiring people to engage as such?
I think it's a very good question to say, is engagement even a useful metric? Because engagement is really a vehicle to get you to an outcome. And there was an interesting paper that came out where, I can't remember the author's names right now, but it said, you know, people with depression, they did a qualitative analysis. We're using apps for 4 reasons towards mental health. And one was just to build new skills. So if you want to learn a new CBT skill and you learn it, you aren't going to use the app for a long time because you learned that skill and you moved on. And so engagement actually in that case wouldn't be the right metric. It would be mastery of that skill, would perhaps be a better metric. Another one said people are using apps to build social networks to support themselves because they're lonely or isolated. So that actually wouldn't be a website like Facebook or Twitter. That actually wouldn't be a mental health app, so that wouldn't kind of come across our radar. But people using apps or social media to kind of build networks. Another one that said people were just curious. There was inquisitive trial. So people just were curious, trying stuff out, and then probably picking one. So there's a lot of apps they would get quickly. And the fourth use case was people wanted to build a safety net, kind of we said around suicide or around danger. They wanted to have a safety net system. So maybe that's a case where engagement will be longer. But as you said, Lisa, even engagement itself may not be the right metric depending on the use case of what people want to use. And we can collect a lot of data without any clicks. We can do a lot of passive data work where the phone, by being a phone, knows where I am right now because I can get calls and texts. It knows if I got a call or text. It keeps track of how many steps I took. It probably thinks I'm tricking it right now. I'm taking steps, but it's pretty good. It's not perfect. It's a proxy. So there's a lot of behavioral data that the phone can certainly gather, and that under this kind of word of passive data, passive being you don't have to engage with it. You literally have to do nothing. And I think it's an exciting new data stream for the field. I think like any new data stream, we have to do our due diligence. Certainly we've had genetics for a while now. We've had neuroimaging. We have EEG. We can gather a lot of data on patients already, very detailed. I would argue, at least clinically, we don't use neuroimaging clinically today. We don't use genetics. There's a lot of controversy about, do we use genetics to guide antidepressants or not? It seems like the tide is turning away. We don't really use EEG very much. So just because we have all this new data, I think it's up to us as a community to prove that it works and to say it works well, to be hopeful, to be excited, to do the right ethical research. But I think just because we can access the data, that's the first step in a process where we have to move forward.
Yeah, absolutely.
And I guess as well, this all of the raw data that can be collected, but then out of that, what actually makes sense in this context, and how do you convert sort of that accelerometry signal into something meaningful specifically for mental health? Step counts and activity make sense, but there's a lot of other data streams, so trying to figure out sort of the best information from the data needs to be considered too.
And I wonder, I think Ipsit, you have interesting, I mean, Ipsit has kind of moved a step beyond and said, do we even need smartphones? And are you there, Ipsit? Or can you, I think, yeah, or you can explain kind of how you've kind of moved beyond even this in your work.
Well, we've kind of had to, because I'm a sucker for punishment, so I chose to work with the absolutely worst population to use technology with, which is older adults with dementia and their caregivers. And we quickly learned that engagement doesn't matter when you're working with someone that can't engage as effectively with humans, much less technology. Conversely, we found that this may be the best population to figure out the broader issue of how to get a patient to engage with care delivered by technology. So we use some smartphones and some wearable work, and we quickly move to a point where what we really need is a technology that doesn't need to be carried, doesn't need to be worn. And if true passive sensing is when the room does all the work or the environment does all the work. So much of our most recent work has moved towards environment and sensing. But I think if we were to take a step back, there's a lot of nuance here around what is a mental health app and what is an app for mental health. I think across the clinical spectrum, the apps being used most for mental health wouldn't necessarily meet the study's criteria for mental health apps. It would be stuff like Facebook, as John said, or WhatsApp is a huge one. I think the broader thinking needs to evolve in the direction of what apps are people already engaged with, and can you use those to deliver mental health? That there are our panel represents a large chunk of the world, but I think the areas that are missing need to be paid attention to. I think it's the areas that countries from the developing world that suffer from access issues. People have smartphones there, and everybody is using things like WhatsApp. I'm involved with some work in India that's not been published. That's actually making the other case that if there are places that there is no psychiatrist within several hundred miles, but people have a smartphone, and there's a way to use it to connect with WhatsApp, maybe we don't need to rethink the issue of engagement. Maybe we need to rethink the issue of privacy and security. What's more important, protecting the communication or getting this person the help they need for something that may not meet the most stringent criteria for privacy? So I think there's a lot of nuance based on who the patient is, where they are, and what part of the world, and where you're using this care in the broader healthcare system locally. We might find that things written in this paper sometimes get turned on their head just by the reality of a clinical situation in rural Africa or rural India or wherever. So we try to stay conscious of that. And I think working with older adults brings that up a lot. We've turned to our patients to guide us on how to use technology. And anyone that's worked with older adults know that this is not a forgiving bunch that sits back politely. If there's a problem, they will tell you. So we've been told things like, I will use something if it's helpful. I will use something if it saves me time. If I have to learn the technology, or if I have to learn the app before I can put it to use and then go through a period where I have to see if it helps me or not, then odds are I'm not going to try this at all. So we've weaned away fairly quickly from apps around CBT. On the other hand, there are plenty of photography apps that we've used to enhance the process of group engagement in art therapy, and it's taken those groups to a whole new level of engagement, not just with the technology but with the therapy itself. John's mentioned mindfulness and meditation, so those are good examples of where I think the app enhances an existing psychotherapy process. I mean, I feel like in the mental health space, we do actually have a lot of tools that work okay. I mean, CBT works, mindfulness works, meditation works. The apps that have been incorporated into standard of care are the ones that somehow simplify or amplify the therapeutic process, where we're not reinventing the wheel. We're just plugging an app into a process deficit and the app enhances it somehow. As the technology, I mean, as to the passivity, I mean, true passive technology is not easily available. We use it because we happen to be in an environment where there are also engineering teams developing it, so you can make those connections. The power of the smartphone is that almost everyone has one, but maybe we need to think somewhat contrarily, and there are things that we have to create apps for, but the lessons may exist already in the apps that are ultra high engagement. That can be leveraged for mental health. I think I know a group in India that's combining WhatsApp with a CBT app that they created themselves, and other groups that are using straight commercial technology for echo modeling to educate PCPs. The thing that they did that's made them so powerful is that they actually stuck with what is known to work and what everyone's already using. So there's a difference there between the engagement with the technology and amplifying the clinical process. I think that's a helpful perspective, one that doesn't necessarily get to John's study itself, but I think it's one step downstream from what the paper's talking about.
Yeah, and if I can just come in for a moment, the other sort of dimension is where people are at in terms of whatever they're suffering from, be it anxiety, depression, or whatever. And I can see, particularly in terms of what you were saying, that apps can be very applicable if appropriately designed for people who are in a relatively good place. But when in crisis, feeling extremely hopeless, extremely depressed, extremely anxious, and so on, I just wonder how useful apps are going to be, except in terms of preparing someone for such a situation when they're in a better place. Do you see what I mean? And maybe trying to think that apps have a place for management of acute crises maybe is not appropriate, except for preparing people and giving them maybe some skills to manage the situation. But when they're in that state, the use of these resources may be very limited.
I was gonna make a comment that's parallel to that, Keith, which is that there are many levels at which we can think of using digital technologies. One of them is just as telepsychiatry, that is, as a direct replace, using an app on a phone like they do with Ginger.io to actually engage with a therapist and do that remotely.
Yeah.
And to actually have your psychotherapy not be in an office, but to be done through an app on your phone. I think that's, well, I'm in Silicon Valley here, where everybody's trying to roll different things out. And I got a text yesterday from the county in which I live saying that they've now opened up their crisis services to chat-based interventions. Mm-hmm. So literally, you can send a text to the county's crisis team, and instead of calling them, they'll respond to you, or they'll call you. But instead of calling on the phone to say I'm having a bad night, you can text them instead. And I think it's important to sort of delineate the difference between, crisis intervention, ongoing treatment, and adjunctive treatment. The app being a substitute for a live intervention, and then even what you were discussing earlier, which is sort of the passive collection of data that can help understand the course of somebody's illness over time, that isn't necessarily used directly as either clinical information or an intervention, but instead as a way of monitoring whether or not somebody's mood symptoms or cognition has changed in one direction or another over time. And I think it's probably worth discussing this in those different sort of columns.
I think it gets to the point too that there's no one treatment that helps with every phase and every part of illness and people's recovery journeys. There's different medications, different therapies, different levels of treatment from outpatient to inpatient. So I think sometimes there is almost magical thinking that there's going to be one app that'll fix everything, one ring to rule them all. You're just going to go, this is the app, this is the ring, it's perfect. And you go, well, no, we're going to have different ones that are good. And I think the test is going to be how they work in a real clinical setting, right? We can do a very good research study here in Boston, in Stanford, in Sydney, Australia, in Toronto. But the question is, what happens when patients actually take this outside of the constraints of a clinical study? Because what we're seeing a lot of the app research too is this idea of a digital placebo effect. And the idea being, well, if you're in a clinical study, you enrolled in a study, you have support, you have the structure of the study, people call you to check in. Sometimes you can get a brand new phone if you're part of a study. And that could be intervention itself. If people line up to get a new iPhone, the study says, here's a brand new iPhone, what's it called, XS or 10S, whatever it's called. And they say, here's your new phone. And oh yeah, by the way, there's a little mood app on it. Did your mood improve? What? Is it the phone? Is it the app? Is it the study payments? Is it the structure of being in a study? So I think we're going to see a lot more high quality studies. And that's not to say current studies are not high quality, but we're going to start to see these kind of really good control groups, these digital placebos. And what was really interesting this summer, a very small paper came out. It wasn't powered adequately, but it was on Headspace, this very popular meditation app. And they actually made a digital placebo version of Headspace. It looked the same, it felt the same. it said it was the same person narrating the mindfulness, but now he narrated sham mindfulness. You had Headspace versus kind of sham Headspace, and in this very small sample that again has to be replicated, we can't say much, but the Headspace app did not separate from the sham app. So this is an app that has 500,000 downloads, 500,000 reviews, millions of downloads. It won a design award from Apple. People do like it. They feel better with it. But it's interesting, when we get a placebo version, what's actually underneath the hood? And I think we'll find out.
That would be good, because I'm spending $12.99 a month for my daughter to be able to use it. So if there's a placebo that works better.
Right. I can send you a weather app for $10.99 a month.
This conversation is a bit of a downer. Look, obviously there are huge problems, and but I like the way you're thinking about things, John. It's not necessarily about finding one size fits all. It's not about finding necessarily a solution for all situations. And I think if we started to think a little bit more broadly and saying, well, what sort of interventions do we think would be evidence-based? It may be applicable to subpopulations. So a 75-year-old gentleman who's never owned a computer in his life, I don't really think it matters how good the app is. The odds are this probably is just a bridge too far. On the other hand, millennials increasingly access the world through apps. And so some interventions specifically for that subpopulation, thoughtfully done, I think that could work. And there's incredible opportunities here. There's a small paper, as you know, published recently in Psychiatric Services that looked at people with first episode psychosis in social media. So, thinking about digital technologies, what it showed was 9 out of 10 use the internet daily. And here was the fascinating bit in Bergham's paper. The vast majority of people access the internet, were interested in information on the internet, including on psychosis, but took over 9 months to talk to a healthcare provider about psychosis. So in other words, these are people interested in information who are out there literally on the internet, and yet hesitating on hanging out with people like you and me. So there is potential, but it's got to be strategically done.
And I think picking up on that point and maybe responding to something John and Keith said, it's not always just about sort of having these apps in clinical services. There have been community trials, like you mentioned, also in the field of suicide, and they have recruited large numbers of participants from the community with suicidal thoughts looking for an online intervention. It may not be a smartphone app, but it is sort of e-health, it is an online intervention. So I think there is scope.
Yeah. And I guess linking to the point that Ipsit made, that there's something about trying not to get too lost on sort of trying to develop the perfect app, actually for lots of reasons. I don't think there's such a thing as a perfect app, but there's endless discussion about how best to involve users and a whole range of users, including clinicians and patients and families, etc., etc. But actually, we could learn a lot more, and we could understand a lot more the things that people actually do already engage with, which aren't necessarily designed for mental health, but which a lot of people also with mental health problems are using, and thinking a bit more about what the effect of those might be, what the dangers, the ways in which they might be used. So I'm thinking, Facebook, WhatsApp, blogs, social media.
I think we also need to give a little thought to our nosology and terminology. I mean, this field started a few years ago as kind of mental health apps, and it's matured fast enough that there really isn't one thing called a mental health app. There can be apps for diagnostics, there can be apps for there can be apps for intervention delivery. There can be straight communications app for access. And I think there needs to be new language around which app is doing what. And I think if we do that, we will find that engagement in one context is not the same as engagement in another context. So I think as the field matures, semantics around what we're calling apps needs to evolve as well. There might be a nice low-hanging paper in there somewhere. But we can talk about engagement in mental health apps today. 2 years from now, to talk about mental health app engagement may be like talking about antibiotic effectiveness, where it's not one thing. It really depends on the bug and the medication. So I think our language needs to evolve as the field matures, because otherwise we're going to end up with imprecise data and imprecise studies, because we won't really know what we were measuring, and if it's two different things.
And just thinking about some of the nuances, of course, we're talking about engagement, and I think we're mostly talking about patient engagement, if you want to use the word patient, or user engagement in terms of the person who's experiencing some mental health difficulties. But I think particularly when we're talking about apps that link with existing health services, there's a question about engagement of psychiatrists and other clinicians and therapists, and I think that sometimes is potentially more of an issue. There's resistance. There are practical and resource barriers in terms of interoperability, and I can't talk about other countries, but in the UK, it's certainly NHS systems are quite complicated as it is. But actually, I think at an individual level, some psychiatrists, psychologists, etc., are quite resistant.
Well, I would say that in this country, the greatest resistance in the mental health field would come from psychiatrists. I think psychologists tend to be much more go ahead for this sort of thing, and psychiatric nurses probably as well. But although the psychiatrists, I think there's always this idea of threats to their domain, even though there's not enough of them around to deal with in any respect. But there's this sort of notion somehow somebody's taking over their role, particularly if it's non-human.
I'll defend psychiatry with 2 points. I would say we've seen a very good movement in the last 2 years that apps need to be patient-centric design, which is critical. We haven't seen clinical relationship design apps designed for use in a clinical setting with both a psychiatrist, a therapist, a psychologist, and a patient. We haven't designed for a clinical relationship and to augment and support a clinical relationship. We've built a lot of these apps as standalone tools, so we actually haven't put the design principles that support me having a therapeutic alliance. A lot of these apps say, log into a proprietary portal, I'm going to fragment your patient's data from all their other data. It's not going to integrate. So if your patient is using an app for medications, for mindfulness, for exercise, you're going to have to log into 3 portals in your appointment and try to put all the data together. The second thing I'd say, at least working with the American Psychiatric Association, I've been spearheading an effort there that we're putting together criteria. We're not going to rate apps to say it's a good or bad one, but helping psychiatrists, educating them about what is a good app, what is a bad app, and giving them a framework to do. So I think the APA has been working hard to acknowledge apps are here and saying, how can we educate people to give them a way to think about apps? What is a rubric to evaluate it? Just like there's no one best medicine. We're not going to say medicine X is the greatest medicine or DBT is always the best therapy. We're not going to say app X is always the best, but we can give people criteria or questions to think about to make more informed decisions. And I think the fact that that's on the APA website, they've endorsed that as a app rating framework, is a good step to see psychiatry working in this space and making steps.
And maybe this is a good point to ask if, thinking around that, if there are any practical tips that you can think about. I mean, David, I know you do a lot of work where you sort of write for, quite wide audiences, right, kind of non-specialist audiences. And I don't know if you've got any tips, or John, on really trying to select a good app, a safe app, an effective app.
I think, I think the lessons to draw from this conversation today, first things first, the app has to solve a problem. And I think often we run into problems, especially with the apps available, that they're not doing something specific. So an app for depression, that's a little far reaching. Is an app for depression about providing people with basic information around medications? Is an app for depression providing them with some common sense CBT techniques that if they're entering into a panic attack, they can employ? Is this not about treatment at all, but diagnosis? So I think we have to be a little bit careful in terms of app development as to who the app is for and why. But then to get back to some other issues around engageability as well. I mean, how are we interacting with people? And it's more than just about clicks. It's also about educating people and informing them, and perhaps even some sort of a human connection. So I'm sure others have comments, but we're at early days, and I think that some of these apps actually show tremendous potential. On the other hand, part of the reason why I think engageability is poor and people tend to drop out is the apps aren't so thoughtfully done. Maybe doing too much for too many would be perhaps the dominant theme.
And I would, for some practical tips, again, it's hard to say this is going to be a good or bad app, but I think some easy screening questions. Is there a privacy policy? If that app doesn't have a privacy policy, just walk away. Another thing is look when it was last updated. If it was last updated over half a year ago, over 6 months, it's probably a zombie app that developer has abandoned and walked away. So you can quickly check in probably 10 seconds, does a privacy policy exist and has been updated in the last 6 months? Again, that's not going to guarantee it's a good app, but those are two really quick screening questions that I would argue may get rid of half the apps in a heartbeat. So in 10 seconds, you could probably get rid of half the apps you're looking at. And again, it's not going to guarantee you're going to find a good one, but it's going to help push you towards decent ones by just saying, when was it updated and does it have a privacy policy? And I think those are just quick, easy questions to at least get you on the right track.
Whether the privacy policy is easy to understand, maybe that's another issue.
Well, I mean, I think, yeah. I mean, I think some of that's
there rather than actually read it, because sometimes,
but you're even at the level of whether there's even a privacy policy to begin with.
We're saying, does it exist before you even take the next step and scan it?
Yeah. No, I think
less than a third of apps have for mental health a privacy policy.
They're catching on. They're beginning to, but there's also a website called freeprivacypolicygenerator.com. And all of you listening, you too can be a proud owner of your own privacy policy at 6 months.
That's hilarious.
Brilliant. So this weekend we're going to scratch an app and get our own privacy policy.
but to what
time
extent?
for the holidays.
Yeah. But to what extent do people think that this should be something that clinicians have a responsibility for disseminating to their patients? Right? I mean, people are going to be using apps whether we want them to or not. And you know, I know you're working with the American Psychiatric Association, John. Other people are working with larger groups. Is there a responsibility for those groups to disseminate this kind of information now that people are widely using things? And is that information actually important to whether or not these things are safe?
I said we do acknowledge people are beginning to use them, and we do have, I think, a responsibility to help people make informed decisions. So if we have new tools and there's new information that has to be considered, I think we do have a responsibility to say, hey, let's at least consider what the security and privacy settings are. Let's consider what the evidence is. Let's consider, is it usable? Let's consider how the data integrates into clinical care. We don't have to have the answer to them. There's many things in healthcare and psychiatry we don't know, but I think we should at least acknowledge these things exist as a first step and make patients aware too that, make them comfortable talking about apps with us. Sometimes just by having a conversation why someone wants to use an app, that gets to a bigger issue of what is the underlying issue, or we can say, hey, you don't need to use this complex program to understand. Actually, you're seeking to understand why your medication is not as effective. Let's make a plan for that. Or let's use an app for this thing. But I think we want patients to know that they should be talking about this with us. And I don't think we want to say we have all the answers, because we don't. But I think we want to acknowledge that things are changing, and we have to consider these things, even if we don't know what the answers are.
So, I mean, I don't know if it's happened already, but one of the key things before we get together a consensus team of people who really understand this field to draw up guidance for clinicians about criteria to consider when appraising an app and thinking about whether it's integrated into your clinical practice and recommended to actual patients. And has that happened already? I don't know.
So look, in the UK, the NHS launched the apps library a few years ago, and it was withdrawn a little while after. I think it's now been relaunched in beta form, and they're starting to collect a set of mental health apps again, which have looked at the assessment criteria, and there's something like a 38-page checklist of information developers need to provide.
Right.
So assuming that information reflects the reality of the apps, mean, within the UK anyway, in the NHS, that's probably a sensible place to look.
It's quite an important project. So, the NHS has been struggling with this for years, and there's some practical issues. But as is so often the case, the internet is a wealth, and I'll include apps and the internet. It's a wealth of information. You can get the best of the best. I mean, you can read journal articles that I, as a practicing psychiatrist, will read, but you can read wild conspiracy theories tying back to Dick Cheney and fluorination of water in California. And so I think increasingly for us to be involved in that discussion with our patients, we're going to have to help them curate that information, right? So if there are 10,000 apps with depression, the question then becomes, how can we join our patients and their families in conversations around picking apps that might be relevant if they want to work on their CBT, or they want to understand more about medications, or if they just want to more understand about the illness state. So rather than saying, we could be part of that conversation, I think increasingly we have to be part of that conversation, because our patients are picking apps and their families are picking apps, and sometimes that's doing themselves no favors.
I think that's right. I think the blog that you have is very nice, because you translate all the research for a lay audience. And I think it gets what Mark said about, we can ask these complex questions about 20 pages, what does your app do? But we all know apps update. I can look on my phone, how many apps want to update right now? 23. So even if we fill out these long criteria, we have all these esoteric points for apps, they're going to update and change. It's not like a medication or a manualized therapy that CBT is CBT, medicine X is medicine X. So these apps evolve and update. And because, again, the research is formative, it's new, we're learning new things every month, there's great new papers coming out. We don't have a gold standard app to say this is a good or bad app. We don't know what the use cases are. So it can almost be, and sometimes misleading, to give a score and say this is a 4.5 out of 5 app, or we have our own criterion, this is a B+ app. So that's why I think we probably have to structure this around informed conversations and personalizing it. It would be nice if we had a library and said these are the best apps. In essence, that's what the UK did in 2015. The NHS had an app library, and that had to be taken offline in public outrage because the ratings, the apps were found to be leaking private data, and they weren't evidence-based. They were giving incorrect information. So I think anytime we try to rubber stamp an app or score them or say, this is the 3 out of 5 app, or using our custom criteria, we get ourselves into a lot of trouble. I think we lose faith with the community, with patients, with colleagues. So I think we have to acknowledge where we are. We all said we're early, there's great work happening. We're going to get to a very exciting place. And this is going to become very important for the whole field apps. I think everyone's realized technology is not going away. But I don't think we want to be at a place where we tell people we're ready to, we have a curated library, and these are the best apps for you. Just 2 clicks and you're good to go. I wish it was that case.
Yeah, but some practical tips on how to navigate the thousands of apps available and some of the key principles, because I agree with, apps get updated or not updated, which very quickly, and in both cases that can be an issue. But some key principles, some key things to what to look out for. And I agree with you, there's perhaps something targeting practitioners directly rather than organizations like the NHS that then sort of goes, oh, hang on, before I can endorse something, I need to pass pages and pages of tests. And by the time I've done that, the app has become obsolete. So it's, and now, as Mark said, there is a beta version of the apps library for the NHS, but it's very reduced. And maybe that's not the point. It's about, and helping patients think how to use them, but not just what to use, but how to use. Because, of course, we've talked about low engagement and what's good engagement, but there are issues around excessive engagement as well with technology. So, can't win, really. But I don't want that to be the concluding comment.
Yeah, that might be. John, do you want to have? Yeah, Lisa, that's helpful. John, do you want to just make one concluding comment since this is your paper that we discussed today?
No, so I said thank you guys for all partaking in this panel, for inviting me, for the panelists, especially Mark, who it's now almost 3 a.m. on a Saturday.
It is. It's amazing. It is calling.
Yeah. And I think
now.
Yeah.
I think, there's no single solution to this problem. I think we need a lot of diverse stakeholders. I think we need a lot of input from different people. I think anyone listening who has an idea probably has a great idea for this. And I think it's just interesting to email probably any of us on this panel if you have ideas, want to partner. It's an area that's growing and we need new solutions.
That's great. Yeah. So thank you everybody for joining us today. It went by faster than I even expected it to do. Thanks to you, John Torous, for presenting your paper today. And for our other guests, leave some David Gratzer, Mark Larsen. Mark, you get to go to sleep soon. Ipsit Vahia from McLean, and a special guest, Keith Hawton from Oxford. I'd like to thank Veronica Heaney for doing this behind the scenes and getting this all set up. I'd like to also acknowledge Andrea Cipriani, who's our editor-in-chief, who's behind all of these Hangout projects and did not join us today. You can follow us on Twitter at EB Mental Health. You can also send comments to EB using the hashtag EBMH chat. Follow us on our website through the BMJ and to read our journal. Thanks everyone for joining us today.
Thank you.
Thank you.
Right.
Thank you.